Good afternoon and good evening. Welcome to this webinar on micronutrients and the adverse effects of proton pump inhibitors. What can we do? My name is Dr. Leslie Kalin. I'm a family nurse practitioner, and I'm so delighted that I get to be here to share with you about this very important topic. Some of you may be very familiar already with some of the concepts that I'll be speaking about today. Many of you, this will be new information. I'm hoping you'll be able to take away today some points that you can bring to your practice and to your patients and really be able to provide a safe prescribing practice for PPIs. We'll get into exactly why I am talking about safety with PPIs since they're so common. Before we get into that, I want to talk a little bit about the platform so you get a little bit familiar with what's happening in front of you. This might be a new way of learning for many of you. So let's just go through a few housekeeping things here. So in front and center should really be your PowerPoint, and you can enlarge that with that little rectangle or square button in the corner of that PowerPoint to enlarge it a little bit bigger so you can follow along with me. I will be manipulating the slides, so you won't be able to go back and have to just follow along with me on that. You certainly want to have the webcam open so you can see me communicating with you in case you are more of a visual learner than just an audio or following along with words. There's also some other windows that you may or may not want to have open during the presentation. One of them being the question and answer. So I will be reviewing the question and answers at the end of the presentation. If you do have some burning questions that you want to make sure that get on the list for me to review at the end, please go ahead and enter them into the question and answer box. We will have some, I will have someone helping triage through the questions to make sure that we get through some of the most common ones. I won't promise I can get through all of the questions. I will certainly do my best. Okay, so you can minimize that box if it happens to be open on this audience view. And if you don't see where you can find those boxes, should you accidentally minimize them, if you scroll down on your screen, there will be a little line of words at the very bottom, and you just can click to open and close those. Okay, there should also be a box discussing me, I guess my bio, so you have a little bit of information about me, who I am. You can also contact me through the little envelope there via email should you have any questions about the webinar or any clinical questions. I'm always open to other people's questions about their practice, in general, clinical questions. There is also another box, I believe, about references and some other things there too, resources for you to look at. So that should be about it for the platform. I do want to make sure that you complete the survey at the end of this webinar. The survey is very short, 4 questions, shouldn't take you very long at all, but we really do appreciate your feedback. So if you can, please do that survey at the end. Okay, I think we have covered all of the goodies so far. So let's get going with this educational webinar. So proton pump inhibitors have been around for about 25 years. The first proton pump inhibitor that came along was omeprazole back in around 1989. It was revolutionary essentially in the treatment of stomach conditions. So since then there have been many others that have come about. Some better, some not better, in a variety of different doses and strengths. They have, of course, become so prevalent that they're now over the counter. So as you might know, as patents end, medications go generic, and then we end up seeing them on the shelves several years later in over-the-counter doses. Proton pump inhibitors are so popular and so effective, really, that we still prescribe them in prescription doses, of course, that you can't get over the counter. But they're so prevalent, they're in the top 10 class of drugs that are prescribed in the United States currently. So we really can't get away from them. And I'm sure many of you have seen patients using these medications for indicated reasons that you and I and the other prescribing clinicians know what they're indicated for, and some not so indicated reasons. I know many of my patients will go for their PPI when they're having diarrhea or just an upset stomach or they caught the flu, and they'll take their proton pump inhibitors for that. Inappropriate uses, but they're so widely marketed and available that and been around for so long that sometimes that's just what patients feel that they need to go for. So what are proton pump inhibitors? What's the indication for their use? So essentially the primary indication, labeled indication for them, is for gastric and duodenal ulcers, so peptic ulcers, in the stomach and in the small intestine. We use them also for gastroesophageal reflux or GERD. When you get that regurgitation of acid into that esophagus, it causes that burning, aching pain, metallic taste, all those fun symptoms. Dyspepsia, of course, that gnawing epigastric pain. Zollinger-Ellison syndrome, which essentially is with the erosion of the bottom of the esophagus from the acid reflux, we get this remodeling of the lining, and very similar to what you'd see in the small intestine itself. So it's the small intestine is healthy, but we don't want the esophagus to have that type of a lining, and that can lead to esophageal cancer. We also use proton pump inhibitors for the prevention and treatment of NSAID-induced ulcers, as well as for the treatment of H. pylori. So that's in the triple and quadruple therapy in combination with antibiotics. Here's just a picture of some of those very common over-the-counter proton pump inhibitors that your patients will reach for, and I'm sure many of you have reached for as well instead of going to your clinician for a prescription strength, and which may not necessarily have been needed. So let's do a quick little review about the gastrointestinal tract itself. So of course, when we eat our food, it goes into the mouth, we have the saliva that's secreted, we move it to the back of the pharynx, down to the esophagus, into the stomach. You probably can't see it on the webcam here where I'm pointing. In the stomach is where we do a lot of the digestion. We've got the hydrochloric acid in there, which we'll talk about in a moment. The small intestine, which winds and winds, which is responsible for more digestion and some absorption. And then, of course, the large intestine is really responsible for formation of the stool and excretion of that last bit of water, or I should say absorption of the last bit of water into the body, and then it's released through the anus. So anything that we don't need, of course, we're going to excrete. The accessory organs now are really the organs that the food doesn't necessarily come into direct contact with. So, of course, the salivary glands, we have them under the tongue, lining through the mouth, where we secrete so those pre-digestive chemicals that help sort of form the food and start the preliminary digestion. When it passes through the stomach into the small intestine, we of course have the liver that manufactures the bile, and we have the gallbladder that essentially holds, it's a reservoir, and then excretes the bile into the small intestine to further break down the food. The pancreas, we're very, very well oriented, I'm sure, with the pancreas, with diabetes being so prevalent in the American culture. Pretty much everybody knows the endocrine mechanism of the pancreas. However, there is an exocrine side of it. I'm sure you all remember vaguely, now that I jarred your memory to your nursing days or your medical school days, that the pancreas has an exocrine and an endocrine function. And so the exocrine aspect of this is releasing lipase and amylase, predominantly enzymes that help facilitate the breakdown of food as well. So we have a lot of different areas in which we have things squirting and coming into play to help break down food so that we can optimally absorb nutrients and thrive. So I want to talk specifically about the stomach, since proton pump inhibitors are most activated and utilized, or their mechanism of action, I should say, is indicated in the stomach. So there's two main cells that I want to discuss. So the parietal cell and the chief cell. The parietal cell is the cell that we use to produce the hydrochloric acid. So I'm taking you way back right now to your to nursing school or to your medical school when we're talking about the proton pump itself. So we have the potassium ions and the hydrogen ions. So what ends up happening with the synthesis of hydrochloric acid is we generally get some sort of a stimuli. We have the cephalic stimuli, so I bet you all know when you were hungry, you smell the donut or a piece of bread or whatever, gets you excited for food and hungry. You start salivating and you start getting the, gurgling hunger pangs, and you just, I want to have that. So that is one of the mechanisms that hydrochloric acid gets stimulated, is so that neurologic response. There's also the mechanical, so when the food gets into the mouth and it's going down to the esophagus, and you get that stretching of the intestine, or the stomach rather, you have that mechanical stimulation as well. So what happens, the parietal cell, when it's at rest, we don't really have a lot of influx in that proton pump itself. But when stimulated, we have an influx of the potassium ions into the cell and an outflux of the hydrogen ions, which ends up creating that high, or I should say low acidity level, or low pH level, high acidity level. So we really need to have that proton pump functioning ideally in order to make the acid that we require to digest food in the stomach. The other aspect here is the chief cell. So the chief cell was the other cell, if you remember from that previous slide, that is involved with digestion. So this is the synthesis of pepsin, and pepsin is an enzyme that's important for the digestion of food in the stomach itself. So again, a very similar type of stimuli. We have the vagus nerve, gastrin, and secretin that stimulate the chief cell to release the pepsinogen. Now, this is very dependent on hydrochloric acid itself. So pepsinogen requires hydrochloric acid to convert it into pepsin. So without that, we won't have pepsin, we won't have this vital enzyme that is very, very responsible for digestion. So you can really see that the hydrochloric acid is pivotal, and it's responsible for stimulating that pepsin. So really it all rides on the hydrochloric acid, so the acid level in the stomach itself. So let's carry on here and talk a little bit about the conditions that we use proton pump inhibitors for. So peptic ulcer disease, of course, when we have that inflammation of the stomach lining and the small intestine, we can develop ulcers or erosions in the mucosa, the submucosa, sometimes into the muscle itself. When it gets really bad, then we're going to have a perforation, and that's bad news. We don't want to get to that point, clearly. I will be touching on the gastroesophageal reflux as a separate pathology that we're later on, but this slide mentions it simply for the ulcer formation that we can get, or the erosive esophagitis that can happen. So PPIs are indicated for that. And then we have the Zollinger-Ellison syndrome as well, which I had talked about briefly earlier. This is just where you can see here the ulcer dips down into the muscle itself. Of course, you'll get some nice bleeding when you have these ulcers that are that deep. When they penetrate into the submucosa and certainly into the muscle, you're going to get some bleeding within the stomach itself. So I wanted to make sure we included this slide about balancing the protective and the hostile factors. So to keep a nice homeostasis within the stomach itself, we need to balance these factors. So we have the bicarbonate, which acts as a buffer to the stomach acid. We have prostaglandins, mucus production, which lines the stomach. It keeps it nice and protective. Blood flow to the mucosa, of course, to keep the cells healthy. What also is a protective factor on here is the normal flora, so the positive bacteria that normally lines the stomach, or the gastrointestinal tract. The hostile factors, which we're constantly battling, it's just like life, we're battling the good and the evil, or the good and the bad, rather. So we're fighting these hostile factors. So H. pylori, of course, the bacteria that can cause all sorts of disruptive symptoms. The gastric acid itself, even though it's a natural product that we need in our bodies. It certainly is hostile. If we didn't have those protective factors, we of course would end up, dissolving our entire stomach from the gastric acid. Pepsin, of course, and NSAIDs. You can also add to that list some caffeine or coffee. Can be very, very hard on the stomach, as well some spicy foods, things of that nature. In fact, even smoking can be very irritating to the stomach as well. So there's other hostile factors, but these ones that are listed here are more on the natural or common side. Of course, NSAIDs aren't really natural, but much more prevalent just in our society. So this slide is just talking about the imbalance. So when we have hostile factors that are outnumbering or proliferating more than the protective factors can balance it, then we get those nasty looking ulcers and then our peptic ulcer disease. Gastroesophageal reflux essentially is the reflux of acid into the esophagus. Generally in the lower part here, but it can go all the way up to the back of the mouth. You can get that metallic taste, that throat clearing, that bad breath, those sorts of things patients will complain about. How this mechanism happens, well, a lot of times it can be mechanical. So in the American population with, 66% or more, don't specifically quote me on that, but of our population is overweight or obese. So we have a lot of the abdominal girth that pushes down and can cause the lower esophageal sphincter. So that's the sphincter, the muscle that tightens where the esophagus and the stomach connect. So when that dilates from a pressure, internal or internal abdominal pressure, we can have that dilation of the lower esophageal sphincter. Hiatal hernias can do that as well. We can also get it more of an organic cause. So if we just lose neurologic tone, that can cause that lower esophageal sphincter to dilate. So this is just a nice picture demonstrating where the lower esophageal sphincter is. You can see with the arrows and how the reflux can come up as that dilates. So let's talk about proton pump inhibitors. So what exactly do they do? So if you remember me talking about that proton pump with the hydrogen ions and the potassium ions, essentially the PPIs inactivate that parietal cell where the hydrogen ions are excreted into the stomach. And so this happens when we're dealing with a, medium or high dose medication. Not all of the proton pumps are inactivated. I want to make that clear that we're not totally disabling this proton pump system in the stomach itself. Roughly 2/3, maybe 75% of the proton pumps in the stomach will be inactivated. So there still is going to be pumping action, proliferation of gastric acid, even when patients are on proton pump inhibitors. So the stomach acid itself is going to be quite inhibited, which will, of course, if we don't have the stomach acid, we're not going to be able to break down food and nutrients very effectively. As we saw, it's the primary mediator in breaking down food. It also won't transform the pepsinogen into pepsin either. So not only will we not have hydrochloric acid, which is a stomach acid, we also won't have pepsinogen, the enzyme that will further break down the food. So there's quite a cascade effect that happens here. So what's the big deal then? Okay, what are the effects of proton pump inhibitors? Well, there's quite a few. Let's talk a little bit about just adverse reactions in general. This might be very new to some of you, learning about adverse reactions in general. And I wanted to include this because I think it's very valuable for clinicians to know about prescribing, that it's not, we don't just have to think about, drug-to-drug interactions and, if the medication is appropriate for the patient, whether they're having side effects, but then there's these, adverse reactions that can be really compounding of other ailments. And so I really wanted to make sure I included this here just as a general point for you to take away. So the Food and Drug Administration has become very concerned about adverse drug reactions. Really, over the last 10 years, they've been really trying to look at the literature after, all these new medications have come out in the market, and they've been able to do the post-launch or post-marketing literature reviews and research, I should say. They're finding that there's a lot of issues that arise from these seemingly safe medications, and proton pump inhibitors are one of those medications that we really deem safe for a long time. So as you can see, adverse reactions in general, so this is not related specifically to proton pump inhibitors, are the fourth leading cause of death over some of these very common ailments that we see. It costs $136 billion yearly. It's quite astronomical, and this does not include any ambulatory patients. So this is hospital, rehabilitation facilities. This is not in the outpatient setting. This is where many of you are going to be functioning, is probably in the outpatient setting. So this slide here, I really want you to take some notes down on, take a picture of it or whatever you want to do, jot it down. I really want you to be thinking about these adverse reactions when you're dealing with a patient with PPIs. Maybe, think about it, integrate it into, your population that you see in terms of, and I'll talk about some of the specific patients that you'd want to be looking at or thinking about in relation to these. But certainly, I want you to be aware of this adverse reaction. So these are the points that I'm going to be talking about throughout the rest of the slides. There is one here that I will sort of touch base on a little bit later, but we didn't include just because there's still growing literature on it. It's, I guess, still the jury's out on the degree of link, but it's iron deficiency or the malabsorption of iron. So you can add that onto the list. I'll briefly talk about that later on. So how does the adverse reaction of PPIs, how does it happen? Well, essentially, if you think back to where we were talking about the hydrochloric acid secretion, the gastric secretion, the gastric acid really should be around 1.3 to 1.8 is sort of normal when it's at its digestive peak. So not at rest, when the stomach is at rest and it's not digesting food, it might be a little bit higher, it might be around 3.2, but when it's active and it's digesting food, it wants to be very, very, very acidic. So that's a low pH. To put this into perspective, if you recall, the scale for acid and base is really on a 0 or 1 to 14 scale. 7 being about neutral. The body is really around 7.4, the blood body. So it's very neutral. It's very neutral. So if we're talking about 1.3 with the stomach acid, we're talking very, very, very acidic. When we use proton pump inhibitors, we're bringing that pH up quite high. So 5, just a couple of points below neutrality. Again, we have 2/3 of those proton pumps that are going to be inactivated. So we still have some acidity to it, but a much, much less acidic environment. So we can absolutely understand how that will create a healing environment for peptic ulcers and for gastroesophageal reflux. If we don't have that burning acid, we certainly aren't going to have those symptoms. So that's a great thing. And PPIs are extremely effective for that. That's why they're so widely recommended and used. However, because we don't have that acidity, we're really doing our body a disservice in breaking down food and nutrients. So it's kind of a good and a bad with healing it. So we need to figure out how to balance that. And we'll talk a little bit about that later. So the adverse reaction associated with the adverse reaction of osteoporotic fractures. So the hip, wrist, and spine are the areas most linked to proton pump inhibitor use. And so most of this data is on long-term use or chronic use, which is about 3 months or longer. So this is a relative risk that we're talking about, not actual. It's an epidemiologic statistic. So the relative risk of spine fractures is about 58%. The relative risk of other fractures is 33%. So when we're looking at spine fractures, of course, who would we be thinking of as our primary candidate if we see this person with a proton pump inhibitor on board? We would see our female patient, postmenopausal patient over the age of 50 who's on a proton pump inhibitor. Her risk of fractures already is up. Her risk of osteoporosis is up, or osteopenia even. So she is the patient that we want to be thinking, okay, PPI, postmenopausal woman, okay, is there a link? If she does have some osteoporotic or osteopenic changes, we want to be proactive in thinking about this link and this risk factor and doing the proper steps to evaluate that. So what happens with the PPI is we need the acidity in the stomach to be able to release the ionized calcium from the insoluble calcium that's in food. So the acid actually takes insoluble calcium and transmutes it into an ionized or soluble form. Without that stomach pH being so low, that's not going to happen. If we don't have that soluble calcium, we're not going to be able to absorb it. Okay, so we really need to have that calcium obviously able to be absorbed in order for it to be sedimented, or at least available in the bloodstream to be deposited and mineralized into the bones, or to at least prevent it as well. So not just remineralization, but also to prevent. This is a nice picture just here of the progression from normal to an osteoporotic compression. Hypomagnesemia. So this is something that I remember when I was a brand new nurse practitioner, or even a student even, magnesium wasn't one of those things that was talked about very much. It was really potassium and sodium. Those are the big ones. But magnesium is becoming much more commonly talked about simply because of the effects that it has on the nerves and muscles. So proton pump inhibitors can certainly inhibit the absorption of magnesium. So this is something that we need to be cognizant of when we're dealing with patients who have pre-existing seizure disorders or irregular heart rate, so arrhythmias and muscle spasms, muscle cramping, that sort of thing. So what ends up happening here is that it's not only the stomach acid not able to break down and absorb, not only break down the magnesium and extract it from the food, it's also an absorption problem as well. So we definitely want to be cognizant of our patients who have pre-existing cramping, arrhythmias, nerve conduction issues in this magnesium. It's a very fine balance, and patients can have substantial effects of it. Even if they're stabilized with their seizures, if we add a PPI to it and they start decreasing their magnesium absorption, they can have an increase in their seizure activity. So very, very important correlation to be making with those patients, because you know with seizures, it's as well as arrhythmias, these can be very, very disruptive and potentially fatal, at least on the arrhythmia side. So the next one I want to talk about is B12. So B12 is an interesting one because it's there's different components in the absorption of this. So not only is there an intrinsic factor involved, but we also need to have the hydrochloric acid involved to be able to break it down and be absorbed. So proton pump inhibitors, of course, will suppress that stomach acid, which will inhibit that the release of B12 from foods, but also remember back to one of the prior slides about the synthesis of pepsin. B12 requires pepsin activity, the enzyme, to be able to make it absorbed in the terminal ileum. So low pH means a less conjugation of pepsinogen to pepsin, which means decreased ability for B12 to be absorbed. So again, there's sort of a cascade effect in the absorption here. So what about C. diff? and the associated diarrhea. Well, there is some growing information or literature about C. diff and proton pump inhibitors. We're seeing it more so obviously in the hospitalized patients who are more inclined to be on heavy doses of antibiotics, very strong doses of antibiotics, which kills the normal flora in the bowel, causes the proliferation of that C. difficile, and then the resulting foul-smelling diarrhea most of the time. Not always, but that foul-smelling diarrhea. It's very distinct for any of you who have come in contact or smelled that. So with the proton pump inhibitors, essentially what ends up, the theory among this in relation to the proton pump inhibitor activation is that it disrupts the normal flora. So when we don't have the normal flora in the stomach, because the acid has increased in the pH, rather, we're not going to have that ability to fight off the bacteria. So the pH in itself keeps these hostile bacteria from surviving. So if you eat something that's got some bacteria on it, the stomach acid, when it's 1.3, it's going to kill it. But also there's this disruption of the normal flora as well. And we'll talk a little bit about that in the upcoming slide here with the community-acquired pneumonia. So similar type of process where we need the acid in order to keep the harmful bacteria at bay. So this is a little bit more of a loose adverse reaction. There's still growing literature on trying to figure out. But essentially when the stomach acid is low, there's opportunistic bacteria that could be absorbed or could disrupt the balance and cause community-acquired pneumonia or hospital-acquired pneumonia. Here's a really nice picture just of a lung pneumonia. You can see the bronchi there really nicely. It's a good picture. All right, so kidney disease. What about the kidneys? So to backtrack a little bit, proton pump inhibitors are metabolized quite highly in the liver. Okay, so we have the breakdown. It's still active somewhat in the bloodstream, although that's not necessarily where the mechanism of action is, but it's highly excreted in the kidneys. So when we have patients who are on dialysis or they're pre-diabetic and we're thinking about our prevention of kidney disease or the risk factors for kidney disease, we absolutely need to be thinking about proton pump inhibitors as well. So keep this in mind, which is really a good portion of many of our patients in the outpatient setting who have diabetes, because we're always very protective of those tiny little vessels in the kidneys themselves. So keep this in mind when you're dealing with a patient who is either at risk for or has chronic kidney disease already. Dementia is, again, one of the most loosely associated adverse reactions, but there's growing literature involved in or coming out talking about proton pump inhibitors and the development of dementia. Very fascinating. We don't know exactly how it works, but there could be some neurotransmitter activation or deactivation that might be involved. Could also be some of the theories because of the reduced absorption of nutrients from the proton pump inhibitors being inhibited. We aren't going to be getting as much nutrients, which will be necessary for the brain sheath, so the myelin sheath on the nerves and whatnot. So if we don't have healthy nerves, of course, we're not going to be able to sustain that brain function, cognition long term. There's also a lot of the vitamins, so like vitamin D, which is actually an anti-inflammatory in a way. And so because there might be an inhibition of some of the absorption of nutrients, we believe that might be the association here with the development of dementia. So this is the really, really fun part. The rest was fun, but this is a really fun part for me. So this is where we get to figure out, what do we do? What do we do with our patients in the bedside? So we know all about the physiology or the pathophysiology of the body and the disease processes. We talked about the adverse reactions and how they can be very substantial with our patients taking the PPIs. So there's a lot of different things that we can do. And as responsible clinicians, we always want to turn to the literature and our guidelines. So guidelines do suggest most all of these recommendations. So we want to be using the PPIs obviously appropriately and for conditions that they're indicated for. Okay. After about 3 months of treatment, you want to start looking at reducing the doses of the proton pump inhibitors, or reducing the frequencies if they're twice a day, once a day dosing, and trying tapering them to the lowest effective dose. Tapering off if you can and just do on-demand dosing would be ideal once the major symptoms are healed or the disease process like the ulcers are eradicated completely. Patients may end up just having symptoms from time to time. There are patients who will require chronic long-term treatment of PPIs, although we clearly want to keep that to a minimum just because of the adverse reactions, or effects rather. We can also use some non-pharmacologic measures. So there's different modalities, research-based and some not. Acupuncture, there's some herbs, different things like that, which of course can create their own effects that you need to be well-versed and comfortable with managing. And then there's also supplementation. So nutritional supplementation for deficiencies. So going back to the question at hand, so what do? We go to the clinical guidelines. As responsible clinicians, we want to make sure we're doing the right thing that's evidence-based. We also, of course, in addition to the guidelines, we want to be, which is documented, we want to be doing our labs on our patients. Clearly, there are some vitamin and mineral deficiencies that are associated with proton pump inhibitors, so we want to be monitoring. Many of our patients coming to us will have, comorbidities, and we're going to be doing labs regularly or routinely anyways. However you choose to do your routine labs, is individual. But we want to be making sure that when patients are proton pump inhibitors, you're doing your electrolyte panels and kidney function panels and whatnot to be evaluating for the noted adverse reactions. Along with the nutritional supplementation, which is sort of an up-and-coming thing, there's one supplement that I think is really, really great that can be used as a preventative and as a treatment for adverse reactions associated with proton pump inhibitors. And this is called proton support. So proton support is a type of supplement that is very unique. There's nothing else out there on the market like it. What it is essentially, it's a dietary supplement that you take 2 capsules once a day, and I will apologize in advance if I ever say tablet in association with proton support. It will be a slip. They are capsules. You take 2 once a day. You can take them in the morning or in the afternoon, with or without food. Doesn't really matter. That essentially will minimize the deficiencies associated with proton pump inhibitors. So it has the calcium, magnesium, iron, which we'll talk a little bit about in a minute, B12. It also has probiotics in it. So when I've used this product with my patients who are on proton pump inhibitors, they will immediately feel the difference if they've never been on any probiotic before. So within about 3 to 7 days, patients will become regular, just simply because of the extra bacteria, good bacteria, the normal flora, is helping the digestion be more effective. So a lot of our patients, clearly they're having gastrointestinal problems. They might have bleeding. They might be irregular. They have these diets that may or may not be, or lifestyle choices that may or may not already be inducing constipation or irritable bowel symptoms. If they're on PPIs, they've got, sorry about that. I think I disconnected there briefly. They may or may not have, irregular bowel movements. And so this in itself, I find that patients, whatever their situation, in terms of their disease processes, will become regular, and they really enjoy it. Some of them aren't used to having a bowel movement every day or twice a day. Normal bowel movements by definition is really what's consistent for a patient, so long as they're not having the bleeding and the hard stools and the hemorrhoids and all that sort of thing. So back in the day, regular bowel movements was daily or twice daily, and now it's whatever the patient feels is normal, which could be every 2 or 3 days. So this is a really good benefit to that as well. Over time, with the routine labs, you can slowly see an improvement in deficiencies that are associated with PPIs with this product. As well, if you give this at the beginning of proton pump initiation, you will oftentimes see a prevention, and you won't see those adverse reactions happening at the biologic level. So with the chemistries. So let's talk a little bit about the calcium that's in this proton support. So calcium citrate malate is a very, very soluble calcium molecule. It's very, very different than what we see in a lot of the tablet forms of supplements that you can buy over the counter. So it's 9 times more soluble, so it's readily available, and it does not depend on the pH of the stomach. So if you remember back to the adverse reactions, or adverse effects rather, we needed stomach acid to release the calcium from food for it to be absorbed. We don't need that here. So the stomach acid could be 14, would never be that, but it could be high, it could be 5, and you'd still be able to absorb this. So this is so important and so good for patients that have that risk for osteoporotic changes. And so the calcium citrate malate is at a nice modest amount. Now you might say, this is much less than what is recommended per se, but because of its solubility, you're actually getting a lot more of that compared to a tablet that might be 1,000 milligrams of calcium. You're really getting a dismal amount. And for many of you who may not be well versed in supplements, when you buy these over-the-counter supplements, their solubility and their effects are actually very, very poor, just simply because of the types of preparations that they're using in providing the supplementation. You have this calcium carbonate, you have some of the citrates and other forms, which just are very, very difficult to absorb, and even more difficult if you have a patient taking an over-the-counter supplement while on a PPI. They're basically just wasting their money. So it's really important not just looking at the amount of supplement, but also the form in which it's coming, because that can be very, very deceiving. Proton support also has vitamin D3, so it's very important to be in the system while you have calcium, because it's part of the deposition or the remineralization of calcium onto the bones. And so proton support has the 800 IUs of vitamin D, which is the recommended dose. So the magnesium mineral in the proton support is 5 times higher than many of the magnesium citrates. So remember, I was talking about the malates, the citrates, the carbonates. So the magnesium citrate is one of the forms that is really not as soluble as magnesium oxide. And so again, here with the magnesium level, it's a mild to modest amount, so we're not going to be worrying about overdosing with any of these supplements. And this is something I really want to clarify too, is that when we're dealing with taking these, if somebody does have a low magnesium, but they have a normal level of calcium or vitamin B12, we don't have to worry about overdosing on one mineral versus the other, because they're modest amounts. The absorption and the correction will be over a longer period of time. We're not looking for something that's going to be corrected immediately, which could certainly cause increased serum levels. So these are really safe to use in prevention and treatment. Just with the treatment use of these, might take a little bit longer for you to get the effect that you might desire on the lab panel. So in that instance, you might want to, if you're doing 6-week follow-ups with your labs, you might want to move it out a little bit longer, or just know that it might take a little bit longer for the correction to occur, simply because of the dosing of this supplement. Going back to the vitamin B12. So the vitamin B12 and proton support is already free form, so we don't have to have any activation here either. So it's going to be, it's freed up already, ready to use, ready to absorb. We don't need the hydrochloric acid again to break it down, release it for it to be absorbed. It's already free and running. And then here's the probiotics. I already, probably embarrassed myself talking about, regularity and bowel movements and everything. But the probiotics are really a key to this as well. So again, going back to the slides on the bacteria, the H. pylori and the C. diff, we really need to have the bacteria on board in order to create this barrier. So I didn't talk too much about it, but I'm going to get into it now. So when you have the lining of the stomach, you have this normal flora that are kind of like, think of like little soldiers. Okay, they're lining up, they're protecting the lining. You can kind of see in that picture there. It's a really good image actually. So they're these little soldiers. So what the normal flora will do, they actually will compete for metabolism of food and nutrients with any hostile or pathogenic bacteria that might be introduced into the body. So the more army you have, the bigger the army you have of the normal flora, the more you're going to be taking away from those opportunistic damaging bacteria to actually inflict some harm onto the stomach lining itself. So the probiotic won't just make our patients regular and come to you and say, yay, I'm pooping every day. But it's actually going to be very beneficial to be a protective mechanism to other bacteria that could be very, very harmful. So it's really, really great that we have this. It also has prebiotics in there as well. So the probiotics, the prebiotics that really help digest the food, but also work as a protective mechanism. So and here's where I'm actually going to be talking about the iron. So in that first slide, talking about all of the adverse reactions, iron wasn't on there. I wanted to talk about it simply because there's some growing literature just in the last couple of years that proton pump inhibitors may decrease the absorption of iron. There's some, hypotheses about that. But also keep in mind when patients have stomach ulcers, they might bleed as well, right? If it penetrates deep enough into the submucosa or the muscle, you can have the bleeding, which can lead, of course, to the iron deficiency, just simply from the red blood cells being purged. So this provides a subtle supplementation of iron, not enough where it's going to cause constipation, enough and a type, I should say, that will be readily absorbed, and also, be preventative in terms of that iron levels dropping, whether it's directly from the malabsorption from the PPI use, and or possibly just from the bleeding that can occur from the disease processes that we're treating with the PPIs to begin with. Vitamin K, we didn't talk about as a deficiency. It's not an adverse reaction. We don't get low vitamin K levels, but it was included in the proton support simply because it helps with the mineralization of calcium in the bones, and so it was added in here simply because the osteoporotic fractures are a major side effect of or adverse effect of proton pump inhibitors, and we want to optimize preventing that and or treating it with the product. So this is proton support, the bottle right there. I'm going to show you a little bit about the kits here. This is the kit, exactly as it appears on your screen. So you can get these actually if you fill out the survey and give us your information. We can send you kits to your office address if you like to try them out. The kits here come with one bottle of 30 days. So there's 60 capsules in here and some coupons and some little brochures. So I'm going to show you the capsules here. I take these. They're actually They might look big, maybe the way I'm holding them on the screen, but they're actually quite easy to digest and swallow. They don't get stuck in the back of your throat like some of those capsules do. So this comes in the kit here, as well as, like I said, the coupons and the little brochures. These little brochures here. I do want to talk a little bit about the loyalty program that Proton Support has. So this comes in the kit here, which you can get if you request it through the survey. So you get $5 off for a 30-day bottle if you buy this. This is good until the end of the year, so December of 2017. And then the loyalty program here, you get $10 off your first shipment of a 3-month supply if it's reoccurring. So this is a really nice deal if you want to start getting going with your patients using that product. So you can, like I said before, you can use this as prevention. There's a nice little quote I wanted to keep in there so we can just remember that this product isn't just for treatment. It can certainly be used as a preventative mechanism too. You hand your patient a script of your proton pump inhibitor and a coupon for your proton support. Oh, speaking of which, since I'm talking about providing that to your patients, they will be providing in about 2 or 3 months little individualized packets that you can, sample packets you can provide to your patients. They're about 5 days of samples. That's about enough time for patients to see their regularity improve, but also to just see how their body reacts to it. They're usually very well tolerated. So those will be coming out in about 2 to 3 months. So stay tuned for that. Also, if you fill out the survey, give us your information. We will inform you of when those packets are available so that you can have them sent to your office as well. Okay, so I'm just going to forward through because we don't have much time left. Proton Support, these are the 2 places that you can purchase the product if you'd like to refer your patients to or you want to try it out yourself. ctherapeutics.com and amazon.com. Those are the only 2 places this product is available. If you're getting it from somewhere else, I can't say that what you're getting is really Proton Support, so beware, but these are the 2 places you can purchase that. This is a little bit about me, and I already talked about the loyalty program. So with about 7 minutes to spare, we can go to the question and answers if you'd like, and we can just open it up there. Let's see here. Okay, I'm going to read this one off here. So this participant said, I am taking a multivitamin with the same components as Proton Support. Are they similar? Well, I can't say exactly that they're identical or similar because I don't know what's in them, but many of the multivitamins do have some of the elements that I just talked about. Most likely, a multivitamin does not have the probiotic in there, so you won't get the benefit of that. So keep that in mind. Usually, most multivitamins purchased over the counter are a multi, and they do not have the probiotic in them. And even most products, many products, I should say, that you purchase, they don't have them together simply because they don't. You know, it's just generally with a multivitamin, they do have to be in tablet form simply because of the different types of elements that are involved. If you wanted to put a multi into a capsule and get them all into that form that will exist in a capsule, your capsule would be ginormous, so very, very large. So very likely that your multivitamin is not the same as Proton Support simply because of that probiotic isn't likely in there, but also I would say it's not likely that a multivitamin, if you're just getting it over the counter, has the same type of compounds in them or preparations like I talked about that are soluble. So many of the over-the-counter multivitamins have insoluble forms, which render them very, very ineffective. So I would really want you to take a look and compare. So be cautious that you're not spending your money on something that may not have ingredients that you can readily absorb. Okay. Let's see. This next participant said, I do not have any symptoms and have been taking PPIs for almost 1 year. Why should I take proton support? Well, that's a really good question, actually. The thing with proton pump inhibitors, as we discussed, is that they're potential risk factors. So you may not necessarily have a predisposition or predisposing risk factor. You might. It's not necessarily that you need to take it or you don't need to take it. What I want to communicate really is the proton pump inhibitors can cause these adverse reactions without you necessarily having symptoms. So do you really need to take it? Are you basing that off of, you having symptoms, or is it based off of, your lab chemistry or your potential risk? So that's kind of, subjective. But in terms of you preventing something from happening or developing to symptoms, oftentimes once we start developing symptoms of something, it's quite far along. So proton support can be used in prevention. So even though you may not have symptoms yet, you still might have the deficiencies. So they are safe to use in prevention, whether you're having symptoms or not, but you can always go back to your blood work. If you haven't had blood work done, you can ask your clinician to get some labs drawn up so you can take a look and see whether or not you have the deficiencies. Even if you didn't have necessarily the deficiencies, the proton support would be safe to use just as a preventative mechanism. Okay, we have just 2 minutes left, so I'll probably only be able to answer one more question here, maybe two. We'll see how fast I can go. Let's see here. When is the best time to take the PPI? Some patients take as needed. How is the PPI helpful? So proton pump inhibitors really, you can take them. Generally, we recommend 30 minutes before you eat, simply because you want to stop the proton pump from being activated. So generally, 30 minutes before you're going to eat, it's about that time frame when your body's going to start telling you you're hungry. You're going to get that activation in your brain that's going to stimulate the hydrogen atoms to be pumped out into the stomach. So you really want to prevent that. So once the stomach acid starts pumping and the protons start pumping, you've already had this proliferation of stomach acid going, and the pH drops. So you're really chasing it. It's kind of like pain and pain management. We don't want to be chasing the pain. We want to shut it off really as early as possible so that we're on top of it. Okay. So generally PPIs are taken about 30 minutes before food, in the morning generally. Although you can really take it any time of day depending on whether or not it's a once or twice a day dosing or an extended release. Okay. So I think we are finished. If any of you, I see many of you have questions, and I'm so sorry that I can't get to all of them, but I will, if you want to leave your information, you can go to that window of mine, and you can actually email me through the system, and I'd be more than happy to answer your questions via email. Okay, I thank you so much for having me today. It's really been my pleasure. I hope you learned something. I hope you're going to be able to take this to the bedside, to your patient side, and really see that PPIs aren't as safe as we are led to believe, that there are some substantial adverse effects that we need to be considered, and giving you some ideas of which patients you need to be more alert with in terms of managing those adverse reactions so we can have safe prescribing and healthy bodies. Great. Thank you so much. Until next time. Bye-bye.